Hi friends, I welcome you all back to Fetal Care. I really thank you all for the extensive support you gave for the previous video. Now let's discuss about the prenatal diagnosis of atrioventricular septal defects today. For that, first let us look at the anatomy and then embryology, types of AVSD and the diagnostic features. Now, this is the appearance of mitral and tricuspid valve when you see from the atrial side. So this is the anterior cusp of mitral valve, posterior cusp of mitral valve. This is mitral valve, left side. This is tricuspid valve, right side. This is called septal cusp, which is close to the septum, anterior cusp and the posterior cusp. In real life, you may not have smooth curvature of smooth curvature of smile. You may have scallops. Both sides. The valve edge may have scallops. Now this is the appearance of mitral and tricuspid valve, and you can see the orientation of the aorta too. It is wedged in between the mitral and tricuspid valve. And this is the real-time picture. This is the septal, anterior, posterior. This is anterior. 3 scallops of posterior valve. Aorta is wedged in between the mitral and tricuspid valve. This is the very important aspect when you see the orientation of the valves from the ventricular side. This is the appearance. You can observe that this is the aorta, this is the mitral valve. You can see the distance. Distance is very small, whereas here the distance is very big. Okay. This is tricuspid valve and this is the mitral valve. This is the aorta. The blood will flow from here to here, whereas here in the right side the blood will flow like this to this side. So now you can see that the distance between the tricuspid valve and the and the pulmonary artery is very high. What happens in the case of AVSD is that this portion of the tissue is absent. This you can also observe that the aorta is nicely wedged. This is the aorta nicely wedged between the mitral and tricuspid valve. So when this tissue is absent, what happens? Imagine if you have only one valve. So how it is going to be? If you have only one valve, it is going to be like this, and the aorta will not have place to sit in between them. So it will be pushed anteriorly. This is what happens. You might either have one ring or 2 rings within the one valve. So the aorta will still be anterior. Okay. Now let's come to the embryology. You can see that the septum primum grows towards the endocardial cushion and it closes the ostium primum. Then gaps appear here. Okay. Followed by that, a second orifice develops. Then you have a second septum developing on the right side. This will not cover completely, and the remaining portion of the septum primum disappears, forming the foramen ovale. So this is the appearance of mitral valve, tricuspid valve. We know very well that the tricuspid valve is more apically situated when compared to or apically inserted when compared to the mitral valve. Okay. Mitral valve. So there is portion is that part of the septum. This portion is that part of the septum which connects right atrium directly to the left ventricle. So it is very important for us to remember that there is offsetting of valves. This is called offsetting of the valves of the mitral and tricuspid valve. So the pathophysiology behind the atrioventricular septal defect is what we know is already is that the failure of endocardial cushion development. This is the endocardial cushion. Failure of this development is what primarily leads to the atrioventricular septal defects. But however, recent studies in mice also shows that the mesenchymal gap and the dorsal mesenchymal protrusion, all this defective development in all this may also lead to endocardial cushion defects. Now, this is how the valves develop, or the annular ring develops. This is one ring, this is the other ring. So both are annulus, two annulus, as you see in the normal valves. Whereas in the case of partial AVSD, you will have a cleft in the mitral valve. This is the cleft in the mitral valve. And also the distance between the anteroposterior distance increases in tricuspid valve as mentioned in few books. The partial and the transitional AVSD will have two separate rings, as you can see here. Not much difference in the anatomy, you have two rings here. Whereas in the intermediate AVSD, you have only one ring. This is the anterior bridging leaflet, this is the posterior bridging leaflet, anterior, lateral. So, what is the main difference between this complete AVSD and intermediate AVSD? You will have the bridging between these two. So, physiologically, anatomically, it is only one annulus. However, physiologically, you have two inlets. So, in this AVSD also, you have two inlets. Whereas this is the complete AVSD, type A. In this, you will have only one orifice. You have one orifice. One orifice. This is the type B. What is the difference between type A, type B, and type C? We will discuss in the subsequent slides. The anterior cusp is smaller when compared to the previous one, and this also smaller because the anterior bridging leaflet overrides or crosses the septum. So let's look at the comparison of anatomy and physiology between these various types that we saw now. Complete AVSD will have one single ring, and then you will have an ASD and you will have a wide VSD. In diastole, if you see, you will have one large gap here. Next comes the intermediate type. Here also you have only single annulus. Sorry. However, you can see that there is bridging between the anterior and the posterior leaflet. So you will have two orifices. Here also you have an ASD and a VSD. This is the partial AVSD and this is the transitional AVSD. Here you have two separate rings. But remember, the mitral valve is having a cleft. It is almost The anterior cusp, this is the anterior cusp, is almost divided into two, and the cleft is more oriented towards the septum. Sorry, the cleft is not towards the aorta. The cleft is towards the septum. Okay, and you will have a atrial septal defect. Whereas in the transitional type, you have two annulus similar to this. You have an ASD, but a very small VSD. Very small VSD. Okay. So, when you see the physiology, these two are partial and transitional or similar. You have only ASD. When you look at the intermediate and complete, you have both ASD and VSD in both. This is how it appears. So, when you look at these three, all the three will have similar AV valve anatomy. That is, you have two separate inlets. Only in this complete AVSD you have single inlet, where the rest three will have two inlets. Now I think you must all be well aware of what is partial, transitional, intermediate and complete AVSD. Anyway, let us look at all this once again. So the number of annulus is 2, in transition also 2, in AVSD, intermediate AVSD and complete AVSD, you have only one annulus. But remember, the number of orifices is 2 in the intermediate AVSD because you have a bridging between the anterior and posterior leaflet. Now, in partial AVSD, you have ASD and VSD is generally absent. In transitional AVSD, there is large ASD, but VSD is very small or it's obliterated by the caudal tissue sometimes. Whereas in the case of intermediate AVSD, both ASD and VSD is large. So when you see these two, transitional and intermediate, when you have a confusion of how to classify, the most important difference is regarding the size of VSD. You will have to find this VSD with great difficulty, whereas it will be very obvious in the case of intermediate AVSD. And in complete AVSD, you have the same large ASD and VSD. And I don't think you will have much doubt regarding the diagnosis of complete AVSD. It will be quite obvious. So in partial AVSD, you have primum ASD. In transitional, you have primum ASD, anterior mitral leaflet cleft, as we saw already. You will have inlet VSD, which is very small and mostly obliterated by the caudal attachment of the septum. And intermediate AVSD, you have primum ASD, large inlet VSD, and common AV annulus separated by tongue of tissue in the two orifices. In complete AVSD, you have primum ASD, large inlet VSD, and common AV valve with 5 leaflets. Partial AVSD and intermediate AVSD will share the following anatomical features, that is trifoliate. You don't call mitral valve, whereas you call it LAVV, and it composed of left superior, left inferior, and left lateral leaflets. The elongated left ventricular outflow tract will be lead to the inlet-outlet disproportion. Let us see about this in detail in the subsequent slides. So now this is regarding the complete AVSD types. There are 3 types as we have seen already. But let us see the details. What is type A? The anterior bridging leaflet is attached to the apex of the interventricular septum. You can see this is the anterior bridging leaflet. Anterior bridging leaflet it is attached to the apex of the ventricular septum. Some say apex, some books say to the sides of the ventricular septum. Whereas in type B, the anterior bridging leaflet, which is partially divided. Here it is completely divided. Here it's partially divided. We saw that the anterior is getting smaller and smaller with the each types. Partially divided is attached to the papillary muscle in the right ventricle, usually on the septal surface. It's crossing over and then it is attached. Crossing over is because it is not divided or partially divided. Whereas in the case of type C, it is completely divided and then it is not attached to the crest of the septum but to the papillary muscle in the right ventricle wall. Attached to the right ventricle wall. This is the difference between the three types of AVSD. But diagnosing them in the antenatal period is very difficult. In normal mitral valve, we know this is the posterior leaflet and this anterior leaflet. The circumference of the posterior leaflet is 2/3 of the entire valve. This is 2/3 of the entire valve. Whereas in AVSD, the circumference of the left lateral, this becomes left lateral leaflet. So is only 1/5. Why? Because you have two divided anterior leaflet. This is the cleft. And one more difference between this cleft mitral leaflet in partial AVSD and isolated cleft in mitral valve is that the orientation of the cleft is towards the septum, interventricular septum. Whereas in the case of isolated cleft in the mitral valve, what will happen is the direction of the cleft is towards the aorta. This is the difference between the cleft mitral valve in partial and in partial. This is in isolated cleft in the mitral valve, which is very there are reported cases postnatally. Isolated mitral cleft in antenatal period is very rare. Detection is very rare. Now this is the anatomic feature that is shared by all forms of AVSD. The atrioventricular valve insert at the same level, this offsetting is absent. You won't have this normal offset. Both tricuspid valve and the mitral valve will insert at the same level. We know that there is absence of septum, and as we saw already, see this is the two annulus, two separate rings, mitral and tricuspid, wedging. Here only one ring, complete AVSD, and one single inlet orifice, and the aorta is pushed up. You can compare both. And we saw that the left ventricular outlet will be elongated. So what happens is, this is how it happens. It gets elongated. So it gives swan neck appearance in the ultrasound. Now let's see the ultrasound part of the AVSD. This is the normal 4-chamber view, where you can see this is the left side, this is the right side, this is mitral, tricuspid valve. Now you can see that there is offsetting. The tricuspid valve is more apically inserted. Observing this offset and documenting this offset is very important. I would personally prefer apical 4-chamber to confirm the offsetting. Sometimes the basal 4-chamber may not give you the real picture about the offsetting of the valves, and there are possibility of missing the partial AVSDs especially. Now, in this picture you can see that there is lack of offset, and this is how partial AVSD appears. Another diagnostic feature is the AV length. When you place the caliper on the outer side of the ventricle and inner side of the atrium, This is called the ventricular length. The atrial length will be between the inner side of the atrium to the insertion of the mitral valve. And when you calculate the atrioventricular length, it is the difference between the atrial ventricular length divided by the ventricular length. The value of 0.6 is the cutoff with the sensitivity of around 86.5% with a false positive of 56%. With the eyeballing, routine eyeballing, you can see that the atrial portion is higher when compared to the ventricular distance. In the partial AVSD, we have seen already there are two separate annulus. Ostium primum, septal defect is present. The defect lies above the separate RAVV and LAVV, and both valves are at the same level. No VSD and LAVV different degree of malformation. So LAVV regurgitation may be present. In the case of AVSD, we call the mitral valve as LAVV, that is left atrioventricular valve, and tricuspid valve as RAVV, that is right atrioventricular valve. And this is the normal lateral view, the same normal apical view. So when you see here, you will have the linear insertion. This is the basal view appearance, and this is the lateral view appearance. So many literature recommend that you have to see in both systole and diastole the lateral forechamber. The absence of this continuity and linear insertion and increased length of the atrium, all this will point out towards the partial AVSD. Detection is very difficult, but it has to be, you have to be very careful in inspecting the valves. So whenever you have this doubt in the offset, it is always better that you document this portion perpendicular to the rays. Still you have doubt, you also go for the lateral forechamber and scroll and see in both systole and diastole to look at the defect. The common pitfall for partial AVSD is presence of left SVC, in which case you will have a dilated coronary sinus. You will see it as a small bulge along the left lateral side of the left atrium. And then even if you still have a doubt, when you apply color, the flow will be from the left atrium to the right atrium. Whereas in the partial AVSD, the flow will be from the right atrium to left atrium. And in three vessel view, you can see pulmonary artery, aorta, and SVC. You will have an additional vessel on the left side in the case of presence of two SVCs or persistent left SVC in addition to the normal right SVC. Whereas if the coronary sinus is dilated to other causes like anomalous pulmonary venous connections, then it might be difficult to diagnose. So let's come to the complete AVSD. The AVSD is best appreciated in the apical forechamber view. In systole, you can see the common valve inserts like a linear line. It appears like a linear line. And in color, you can see AV regurgitation. As the severity increases, the chance of developing hydrops also increases. In the case of diastole, you can see a large gap. You can see the complete mixture of blood, as there is only a single inflow channel. There is mixture of blood in both atria and the ventricles. If you look at the first video, you can clearly see that there is increase in the atrial length. And just by eyeballing, you can understand that there is increase in the atrial length. Now, this is the opening and closure of the common valve. You can just see there is only one inlet, and it is equally opening into both the ventricles. The size of the both ventricles are almost the same, and the blood is equally, you can appreciate the opening is equally distributed. Now let's come to the second picture. In this, clearly you can appreciate there is two inlet, whereas there is only one valve but two inlet. You can see one large VSD here. There is a ASD here. You can see the ASD clearly. Two inlet. I repeat it again. Linear insertion. Two inlet. Linear insertion of the valve. VSD. And I'll show you the ASD. This is the ASD. Okay. So what do you classify this? Here you can appreciate even more. Two inlet, linear insertion, VSD is evident here, VSD is evident here, ASD clearly seen. Clearly ASD is seen. So this is intermediate type of AVSD, where you have two inlets, VSD, ASD. These two are cardiac image of the same patient. And this is a case of intermediate AVSD. And this is how you differentiate between complete AVSD and intermediate type of AVSD. Now the difference between the intermediate and the transitional type of AVSD is that in this area you will have restrictive VSD, or the VSD will not be this evident. It will be a very small VSD and you will have to put extra efforts to visualize that VSD. And that is the difference between the transitional and the intermediate variety. We have come almost to the end of the session. Now, AVSD, based on the commitment to the ventricle, it can be divided into two types, like balanced and unbalanced. When the AV valve is equally committed to both ventricles, then it's called balanced. We saw in the previous video of AVSD where it was equally committed to both ventricles. Now, there may be a situation where the AV valve is mostly or primarily committed to only one ventricle. Like in this case, it is committed mostly to the right ventricle, and then the left side portion becomes small, including the outflows leading to outflow obstruction or arch abnormalities and aortic valve hypoplasia, etc. When left side is dominant, the right side structures undergo hypoplasia like right ventricular hypoplasia, RVOT obstruction, pulmonary stenosis, and atresia. Friends, if you want to have one message from this presentation today, I would say look at the offsetting of the valves, preferably in apical four-chamber U. That will help you in diagnosing the partial AVSD quite easily. I thank you all once again for the extensive support that you have given me so far.